And as Dr. Preeti said, it's not possible to teach you people whatever is there in any subject and at your stage. So as a teacher, that our duty is limited to give you this thing, some background information, and you have your whole lifetime to read about that and improve on that. So we are still doing that. So what I would be doing would be, first part I would be covering medical record and clinical audit. And needless to say, in today's era, medical records are very important. So, but what exactly is medical record? So basically it is a collection of data on patient, including history, statement of current problem, diagnosis, and the treatment procedure. And why do we need medical records? So needless to say, the primary uh, benefit of it would be, it would support your direct patient care. So whenever this thing patients come in OPD, if you have kept your record properly, you can remember by looking at record what was the current problem and what was the past history like. Then second is for communication. Communication with the patient and with your colleagues and referring departments as well. But as important as the primary function, the secondary functions are equally important. So a proper record keeping help you in clinical audit and research, resource allocation, like depending on a department's records, how many patients a particular department is treating, hospital administration may decide, okay, this much of resource would go to that particular department or this department, what is their basic need and what is their basic output. So not only for indirect patient care, but there are so many other functions it serves. Then second would be how to plan service. Then based on record, they can they can monitor performance of the department, like how many inpatient, outpatient, and if it is a surgical department, what is perioperative mortality like, whether it is matching with international or national standard or not. The third and the one of the most important thing, and you people must have realized in today's COVID era, is epidemiology. So it aids a lot in this thing, epidemiological studies. Then last but not the least, medical legal. And it is very important to understand, currently whatever this thing goes in record, each and everything becomes a potential medical legal issue. So you have to be very careful while entering and maintaining medical records. So there would be two aspects of any medical record. First is how do you enter or fill the that pro forma or database. Then second is keeping and maintaining the record. So needless to say that if whatever entry goes in, so it must contain sufficient data to identify patient, support the diagnosis or reason for attendance at healthcare facility, justify the treatment, and accurately document the result of that treatment. So I'll come to that in detail a little while later. And then one of the important, from this thing resident point of view, we are always bothered how to this thing, your consultant would also be shouting or literally would be behind your back to enter the record and maintain, but maintenance is equally an important part of record, and it becomes very important when we are dealing with medical legal issues. So while this thing maintaining records, there are so many issues involved with it. The ownership of the record, who owns the record, then storage, retention, and destruction, if it is done, how it should be, how we should be going about that. So many of these things would not be uh, directly concerned to you, but once you go out from this hospital, you may be a part of some management of some hospital, or you may be planning to start your own. So all these things become important then. So, and if you go through any records, so if you just casually look at the record, so there are four important components in which you could uh, classify your entries. One is administrative part, second is legal part, third is financial, and fourth is clinical. Administrative part, but all these things are not exclusive. These are interrelated. So administrative part would include patient identification, patient's residence, and so far as our hospital is concerned, CR number. And then contact number. But these things are not only important for administrative point of view. We very well know that judging by patient's age, gender, area of residence, it has influence on your diagnosis making and your intended therapy as well. Then second part is legal data, one of which has nicely been covered by Dr. Supriya, that is some of this thing consent forms, and then there could be other authorization certificates, that release of patient from some mental facility or one transfer of patient from hospital to others. So all these could become part of legal data. Then needless to this thing state about financial data, there would be always a account statement attached with a patient's record. Then the most important thing for us clinician is clinical data. And clinical data, we would be entering this data day in, day out, whether the patient is in inpatient facility, outpatient, emergency, or ICU. So far as our medical records are concerned, so as I just said, the main important thing to remember for resident would be inpatient records, discharge, and death summaries. But equally important are outpatient records and medical certificates. So how should we be entering medical records? I think all of us know from our medical school days how to go about it. There is nothing new about this thing. So I would just be reiterating the important points. So needless to state that all documents should be written in legible way, or ideally should be typewritten. And if there is this thing confusion about some drug or diagnosis, it's always better that you write those in capital letters. In fact, last week only I had a patient, then resident came to me. The patient was on chemotherapy. Patient is complaining of facial puffiness, weight gain, and we realized that patient was taking prednisolone instead of pyridoxine. So this could happen. So wherever there is chance of such error, it's always better that we should be writing in capital. Needless to say, scribbling must be avoided. So we doctors, at least I don't have very good handwriting, but we should try to achieve that perfection. And records must be accurate, up to date, placed in order, and complete in all respect. And try to do it at all times wherever you are posted. And if you are making any alteration, it's always better that you obliterate the previous writing or whatever scripture is there with a straight line. You just cut it. Don't try to obliterate the previous entry completely, and then it should be countersigned. So it would only be done if you spend some time to fill this record and prepare the record. And if you are in practice, you can always appoint a clinical associate with you. So now coming to inpatient record. So what is an ideal way of doing it? So I have taken these recommendation or guidelines from Royal College of Physicians. Those were published in 2008. So whenever patient is in inpatient facility, we should ensure that all the complete medical records are available all the time during their stay in hospital. Every patient, ideally, in medical records should include patient's name, hospital number, and location of hospital. Though in our hospital, only the primary part where detailed clinical history is there comes in pre-formatted pro forma, and other pages we just paste in loose manner. But ideally, suppose this thing, some pages are lost or get detached, you would be able to attach those to proper file if all the pages contain patient's name and CR number. Then there should be a standardized structure and layout. In our hospital, you people must now, by this time, you must be acquainted with consultation forms and certain requisition forms, which are already in standardized format. Wherever possible, that is guidelines from government as well, that you should be using generic name rather than commercial names of the medications. And whenever this thing, you are filing these records, there should be a continuum. It should not be that you have seen patient on 5th, but the entry of 10th is coming ahead of 5th. So there should be a continuum. It's always easy to understand what is happening with the patient when the records are in proper order. And ideally, this thing, all the records of admission, handover, and discharge should be recorded using a standard pro forma. We don't have a generic pro forma for our hospital, but different departments have devised their own. Like this thing, if patient is being transferred from surgical facility to post-op ICU or post-op ICU to CCM, they have devised their own pro forma guidelines for handover of the patients. Ideally, when the patient is in hospital, there should be at least one entry every 24 hours. And whenever you are making that entry, you should identify the physician who is responsible for care of that particular patient. So you should be writing this patient was seen by such and such consultant by name, and at the end of this thing record, you need to put your initials as well. And needless to state that entries to the medical record should be made as soon as possible after any this thing event, so that documentation is in time and before, because we know this thing in hospital, all the paramedics, they are on shift duty. Even this thing, you people would be leaving hospital at some point of time. So before you hand over the patient to next team, your entries should be complete. So this I have already told. And whenever this thing, the patient is seen by or supervised by a senior consultant, that event should be recorded, duly recorded in the file. And if you, because this thing, hospitals are becoming increasingly busy day by day, so it's possible that you may not be able to make a detailed entry every time. Like a patient is post-operative patients of very simple procedure. For example, mastectomy, you just write patient no complaints and continues same treatment. But at least even in those patients, after every third or fourth day, you should be putting a detailed entry regarding this, and particularly at the time of discharge, that this patient was admitted with this such and such problem, underwent this procedure. Now patient is uh, deemed fit for discharge, and with advice for follow-up on such and such date. And ideally, this thing, we have electronic record system. So as soon as patient gets admitted, you should start preparing or entering in the patient's discharge summary, so that you don't rush that up at the time of discharge. And if there are any advance directive, consent, and resuscitation status statement, that should better be obtained or clearly recorded in ahead of time. So this I have taken from WHO statement. Uh, so any distinct front sheet, and our distinct front sheet of our case record file also would somehow would be like this. So there would be administrative record, then there is clinical record, and in our hospital after that we put financial data and consent and other legal documents. Now coming to another important record, that is discharge summary. So discharge summary, though it is summary, but the minimum details which are required here would be, needless to state, patient identification that will come automatically so far as our system is concerned once you start preparing that record. But you have to mention why the patient was admitted, meaning thereby diagnosis, and if any intervention was performed on that patient, and what was the this thing at the time of admission, what were the clinical findings of the patient, was treatment patient received, what was the course during hospital stay, and what is proposed follow-up with specific date and time for follow-up visit. And even this and if you are discharging the patient, uh, that time you should also mention whether this thing patient need to come back, or if the patient is being referred to other center, even if the patients those who are getting discharge against medical advice, they are entitled to get a discharge summary. It's a this thing wrong notion with this thing among many of us, that patients who are getting discharge against medical advice are not entitled for discharge summary. They are. They have paid for your services and they are entitled whatever this thing had happened to them during your hospital stay in any of the hospital. But one important thing to remember, and particularly like I said, our is an electronic record system. For one patient, there would be only one CR number and one medical record. It happens sometimes that patients, they get confused, and this thing, if there this thing OPT ticket is valid for 1 year, and after 1 year they have to get that thing renewed. But it happens that patient, because of ignorance or due to some other reason, they obtain some other CR number. So what happened if a particular patient is getting a new CR number, all the information which were attached with previous CR number would be lost. So that is not ideal situation, and you can understand, due to not only because of inconvenience, there could be so many medical legal aspect attached to it. So whenever this thing, you think that something of that sort has happened, you always mention that this patient's previous CR number was such and such, because it could be just because of ignorance of the patient and not intentional. So after that, how do you this thing file or this thing store that records? Ideally, all the, if you are doing its own, your own, in big hospital, the medical record department would take care of this aspect. But if you are doing it your own, or your this thing running your own hospital, then you should be maintaining different registers for different kind of records. So in those registers, there would be entry like from this year to this year, or this number to this number is stored in that particular place, and so on and so forth. And it's very important for medical certificate. You should maintain a separate register, and all the medical certificates should be prepared in duplicate. And there should be at least one identification mark of the patient mentioned in the medical certificate. And whenever you are issuing that medical certificate, you obtain a receipt in form of signature or left thumb impression. Now, who owns these records? So first and foremost, owner would be patient. But so far as our hospitals are concerned, and big or corporate hospital, government hospital, the hospital administration own these records. But if you are in private practice, then you are owner of these records. So uh, uh, in hospital, like big hospital, as I already said, there would be a designated medical record officer and there would be a medical record section. But when you are doing its own, then you need to develop your own system, how to keep those records. One would be concern of safety, and then second would be concern of confidentiality. So, but it happens with paper records, like this hospital is seeing more than 500 patients per day, and we must have treated so many patients over 3 or 4 decades. And initially, and I think currently in India, most of the hospitals run on paper-based records. So it's not possible to keep those indefinitely. So what is the law about destroying these records? So far as our law is concerned, there is no clear-cut timeline beyond which you could destroy the record. But it is important to remember, why would you be needing this record apart from your own academic purpose or follow-up patients? The one of the most important thing would be medical legal. So Consumer Protection Act advises that patient record should be kept for 5 years if the patient was inpatient facility, and for 3 years if patient was an outdoor patient. And if you look at Medical Council of currently it's this thing NMC, but erstwhile Medical Council of India recommends for at least 3 years of preservation. And it is important to remember that limitation period for filing a case in consumer court is 2 years. However, this period could be relaxed provided that consumer could provide an evidence that there is sufficient ground to open a old case. And if the case is medico-legal to begin with, like trauma, burn, injury, in those cases, you should be preserving these for at least 30 years or at least until the final settlement of that case has been decided by the court, and in our distinct country that would be Supreme Court. So if you are keeping the records, so what is the situation regarding sharing or divergence? Would you share those records with anyone? No. So but if this thing some third person asks for any other person's record and RTI, you are not supposed to provide those. So at present, medical records are not covered under RTI Act, and we would be held liable if we disclose a record or contents to any unauthorized person without consent of the patient. Similarly, we are not obliged to share patient's record to insurance agency or employer without patient's consent. The employer could even be government. However, courts have power to summon any medical records if required. Then there would be a certain situation where you have to share those records. So if person or patient or his or her authorized representative requested for records, we are supposed to share those records. Otherwise, that would be amount to professional misconduct. And like just now I said, even DAMA patients are supposed to get a discharge summary. In case of death, a legal heir or next of the kin should be issued the death certificates. And as I said, patient's records cannot be used for any purpose. However, in hospital, we can use those records for statistical data for quality care determination, even without their consent. But because that is a kind of group records, you are not looking at any particular patient's record with identification. So if you are using any, like if you are publishing or you are presenting any case report about interesting case, you should ensure that you would not be divulging patient's identity. If you are sharing any photograph, in those cases, you should ensure that eyes or face are covered. And suppose in some cases, if those are your distinct interest of that study, so try to cover at least one area. Like in, I want to present a case of Graves ophthalmopathy. So, but even in that case, I would be covering the lower half of the patient's face so that his or her identity is not revealed. And similar to, it is very important to note that our laws are evolving and going by whatever newspaper records, and in future these laws are going to be very stringent. And if you look this thing at US, they have very strong laws, and so much so that even if I take a decision about my children's treatment or therapy, in future children can sue their own parents. So we are not saying we are gradually reaching to that state, though we are quite far off from that state. But the crux of the matter is whatever this thing goes in your medical record is a cause for potential legal dispute. So be very careful about your records. So now coming to policy of destruction of medical records. So even when this thing, there would be situation that you cannot keep these records for indefinitely. So you would be there, and the need would arise to destroy those records. So even when we are destroying, there should be this thing, minimum identifying information should be retained. That would be patient's name, identification, admission, discharge date, what was the name of attending doctor, what was the diagnosis for which he or she was admitted, and discharge summary for each admission. And whenever this thing restriction is in is required, it should ideally be done by burning, and an authorized person or medical record officer or whosoever this hospital administration designate should personally supervise that these are being destroyed properly and or these are not being passed over to unauthorized persons. So many of you would be going and doing private jobs or practice. So you have to evolve your own system. But main important thing to remember is always this thing, keep your records secure, and if possible you should this thing contact a facility if this thing some third party could store records for you. And the most important thing is that these should not be uh, access to unauthorized person, and confidentiality should be protected at every cost. So at the end of the day, we are bound by Medical Council of India, and Medical Council of India in 2016. In fact, these regulations came up in 2002. Those are professional conduct, etiquette, and ethics regulation, and amended in 2016. And according to this act, as I just mentioned a while back, that you should be preserving records for at least 3 years. And whenever patients ask for records, you should promptly acknowledge that request and and we are liable to, by law, deliver those records within 72 hours and maintain a separate register for medical certificate, and every attempt should be made to computerize medical record for quick retrieval. So needless to say, the Digital India is our government's initiative as well. So what are the potential problem? Potential problem which are this thing liable for some consumer protection litigation, or the problem which could arise during that litigation. One is that you fail to provide a signature or legible printed name. So what happened, like in OPD, if you're sitting in OPD, you don't put the date. So in future, patient could claim that patient, he or she reported on certain other date, but this thing, you insist that you saw that patient on particular date and following like fifth post-op date, this particular event happened, but patient could claim otherwise. So it's very important that you put a signature. There is a, I think, standard guidelines how to write a prescription. You should stick to that, because that could be used for so many other dubious activity, that outpatient visit, if you are not correctly recording it. And during CPA, if there is a this thing evidence of manipulation, like you have written some medicine or prescription, then you have this thing tried to completely obliterate it. So it would always be taken that you prescribe something wrong and then you try to correct it. And as I said, like being human, we could this thing make mistake, but when you realize this thing, you just this thing strike it off neatly, countersign it, put a date, then this thing write the correct medicine or whatever correct this thing advice you thought. Then if you this thing, particularly in our this thing institute, you people should remember whenever there is a mortality, that time you need to retrieve all the x-rays. If the patient's or attendant, sorry, patient obviously could not give consent. So if attendants refuse to provide you x-ray or other this thing image finding, but because as of now our PACS system is not very robust, so in that case you could always take a picture, because that could come up not only in institute academic mortality discussion, we could this thing be asked to produce those records during CPA. But usually this thing, our instruction is key, those records should be kept with the hospital in patient's death file. So what is the corrective measure for this, all this, to avoid all this potential litigation is habit. So make a habit to enter record properly, always this thing follow a system. So it is not only important for patient safety, but your own. So what is current trend? As I said, WHO has also envisaged that all the records should be made electronics. So what do we understand electronic medical records? It's not just that there's a computer and I enter patient details in that record. Actually, EMR is a real-time patient medical record with access to evidence-based decision support tools that can be used to aid clinicians in decision making. So that is the ultimate EMR. So I need not to elaborate what would be advantage of this, but as I said, mainly this thing EMR come with clinical decision support system or computerized provider order entry system. We don't have CDSs as of now in our hospital, but we do, whosoever have, you people have already started working on HIS, and you know that we have CPOE in our system. And future of these electronic medical, usually electronic medical records are devised for a particular hospital or group of hospital, chain of hospital, but future is key, we should be creating or such kind of EMR which would be exchanged with within different facilities or systems. And WHO has devised a system of implementation of these electronic medical records. So stage 0 is, as I said, some computation is present. That doesn't mean we are having EMR. We are having some computation, but the stage 1 would be only when all the major ancillary system like pharmacy, laboratory, and radiology are installed on the system. So we have this. Then if they are providing their reports and clinician could access those reports, then we have reached stage 2. Stage 3 would be that we are doing all our clinical documentation on EMR, so that any person sitting anywhere who has access to that system could visualize those. Our current HIS lack this thing, but we do have CPO system. And as I just said, that clinical decision support capability is still to be enabled. Then stage 5 would be that at least one patient service area is fully become paperless. And if the whole this same could be implemented in the whole hospital, that would be stage 6. And stage 7 would be you don't need any paper in any record, and all the records, discharge summary, death summary, prescription, patient's details, case sheet is in system. So our system is somewhere between stage 4 and 5. Like I said, we lack CDSC, but we do have CPOE. So now, nowadays, this thing, there's a term mostly heard during news or this thing, many deliberation by government agencies, that's this EHR, electronic health records. So how electronic health record is different from an electronic medical record? The only difference is that electronic medical records about your this thing, disease or disability, and when you have an encounter with hospital because of these situations. However, electronic health record is a record which maintains all the records of all your encounters with medical facility. That could just be for vaccination, pregnancy, delivery, routine clinical screening, so on and so forth. So there is a difference between EHR versus EMR. Then on the same line, there is something called personal health record. Personal health record is same in the line of, maybe it is a combination of EMR and EHR, and that is personally owned. Not in our country, but in the same elsewhere, it could be maintained by a person himself or his or her legal representative. So, as I said, this thing, not only our this thing government, but World Health Organization has also amended that all the nations should try and this thing, try to make a national body and try to digitalize all their records. And in this direction, our government has been very proactive. And you must be hearing that we digital health mission and all these are at the forefront of government policy, and they have already come out with electronic health record standard for India. So the last version was published in 2016. So if you people sometimes, if you have time, please go through this document. This may not be relevant today, but in coming days it could be very important for you people. So at the end of the day, what is the purpose of this EHR or EMR? So we would be proceeding ahead towards e-governance, and whatever this thing function, routine medical records serve would be served by this EMR or EHR. Now a bit about clinical audit. I know all you people are tired, but this is also an important section. This thing for which you should have a at least nodding acquaintance, and I'm sure during your project and other research presentation you would be getting more clarity about the subject. So basically, what is clinical audit? Clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systemic review of care against explicit criteria and implementation of changes. So we need to, what we are trying to do is we are trying to review our whatever treatment policy or outcomes against some set standard criteria, and if we find some deficiency, we are trying to implement change based on that audit. So what could be audited? Any aspect of structure, process, and outcome could be evaluated against explicit criteria. Where indicated, changes are implemented at an individual team or service, and further monitoring is used to confirm improvement in healthcare delivery. So at the end of the day, what we are trying to do through clinical audit is to improve our own clinical services. So what is the utility? So basic utility is key. We are trying to assess or discover how well clinical care is being provided and to learn if there are opportunity for improvement or not. It may be used to improve aspect of care in wide variety of topics. For example, medical delivery system, ICU system, or daycare system, anywhere you can use it. And it can also be used in association with changes in care provision or to confirm that current practice meet the expected level of performance or not. Like we have, if I give you example, I'm basically an endocrine surgeon. So international standard for total thyroidectomy would be that which the centers which are performing total thyroidectomy should be having a permanent hypopara or permanent rectal palsy rate of less than 2%, or now they have come up with less than 1%. So we should this thing, if I want to do my clinical audit, I can do it many ways. First, to start with this, whether we are meeting those standard or not. If yes, okay. If no, so then we try to find what are the areas for improvement, whether it would be just our technique or adjunct we use during surgery, like energy devices, bipolar copy, so on and so forth, and you could this thing extrapolate to your own field or services. So why should we be doing this thing, clinical audit? So needless to say that it would uphold professional standard, and we will have a feeling to do the right thing. Regular audit helps to create a culture of quality improvement in the clinical setting, and through clinical audit, healthcare staff may identify, measure area of risk within their services. Clinical audit is educational for the participant. So if you are this thing, I'm sure during your stay of 3 years at SGPGI, all departments, they are regularly doing a clinical audit, and we learn so many things out of those audit. And if at the end of the day we find that our standard match with international standard, obviously you have this thing, feel pride and satisfaction that you are doing this in right way. So then you must be thinking, this seems like research only, while we are trying to achieve so much through audit. So how research is different from audit? So when we look at research, research usually focuses on a very particular or very specific question. So what research asks? It is what is the right thing to do and what is the best way to do it. If I come back to our thyroid pathology, so for multinodular goiter, I would ask you which modality of surgery is better, or first, which modality like medical surgery or radioiodine is better. If surgery is better, what is better, hemi or total? So if I have to answer that question, I have to devise a randomized control trial or whatever prospective study in order to get answer for this question. But then how clinical audit is different? So suppose by research we have already established that total thyroidectomy is better. Then what question I would be asking during audit? Are we doing the right thing and are we doing it the best way? So coming back to the same example, so if suppose surgery is the best modality of treatment, so during audit we would be asking whether all our multinodular goiters are getting surgery or not. If yes, and as we have already decided total thyroidectomy is better, whether we are doing total or we are doing subtotal. So that's how it is different. Research provides you answer, and then in audit you see whether that policy is being implemented or not. So this is the same this thing comparison, but at the end of day there is no watershed between clinical audit or research, because whatever answers you get from research, at the end of day you would be implementing that in your clinical practice. And research is a one-time project. However, audit is a continuous cycle. So you set a criteria, define a standard against which you are going to do audit. Then you start collecting data. Then you compare your data with the set standards. Then if you find some deficiency, you try to implement change. Like if I find our this thing retinal palsy rate is 5% and I decided that our training is deficient, or I should be using bipolar cautery or electronic ultra scissors. So I would be implementing those instruments or those techniques in my practice. Then I would again see what is the outcome. Have we improved or not? So again, it's this thing, we set a new criteria and we try to evaluate our performance against those criteria. So to conclude, I would say that medical records are an integral part of medical profession. I need not to reiterate this. These documents are important not only to doctor or patient, but in society, uh, but for society in general. As we have just this thing, if you look at this thing, our current time, COVID. So different hospitals start collecting data. Then at the end of day, this thing, then you decide what, when data is there, only then you would find what are the risk factor for admission, what are the better modalities of treatment. So not only you, if you keep your records properly, you would this thing be serving society also in general. But forget about this thing, this is very important for your own safety. As I said, that medical legal cases are rising day by day in India. So please take out some time from your busy schedule and try to uh, fill a proper record and maintain them properly. So I would end here. Thank you very much. And I would be happy to take any question if any. And as I said, I have taken some of the guidelines from medical records manual. And if you have time, please go through these manuals and electronic health record standards of India. Thank you very much.